everyone should have access to all of the resources that are necessary to get them through that very difficult and painful journey of being diagnosed with, told you have cancer, and then coming up with a treatment plan and getting through whatever that treatment plan might be.
Welcome to EHA Unplugged, the EHA podcast. I'm your host for EHA, Robin Doeswijk, Head of European Affairs at the European Hematology Association's Executive Office. And our guest today is Professor John Gribben, a very distinguished guest, past president of EHA, as well as, importantly, former chairman of its European Affairs Committee. John, would you please introduce yourself a bit more?
So, Robin, as you say, I'm John Gribben. I was the president of EHA. I like to always call myself the COVID president because, of course, I was president during the whole COVID pandemic, of course, which meant that I didn't have a congress unlike this one. I as you said, had a role as a chair of the European Affairs Committee, and I've had a long interest in a question we're going to be talking about today, which is about equity of care for patients and making sure that all of our patients in hematologic malignancies get access to the care that they need. My own special area of interest is in management of leukemia, lymphoma, stem cell transplant, CAR-T, immunotherapy.
Thank you. Thank you very much for being with us, and it's a great pleasure. And I think, on the positive side, you can say that you have managed to lead EHA through the most rocky times, and we've kept our work continuing. And you mentioned an important focus of that work: equity of access for patients across Europe, affordable, equitable access to innovative therapies. That has been our long-standing advocacy priority. And it is the all-important context for what we will be discussing today, which is the essential requirements for quality cancer care and the EU cancer policies that are currently shaping up, and for which we are trying to position hematology as an integral part. About those essential requirements, the European Cancer Organization Essential Requirements for Quality Cancer Care in Hematologic Malignancies. That's not exactly a very catchy title, is it?
It's not very sexy, is it? But of course, the European Cancer Organization is our partner organization, and one in which I know you've been doing a great deal of work, because they also share with us this view about the need for equity. They have, for a whole variety of different malignancies, put out these, what they call essential requirements for care. So really, that very long title just means, what do we need to ensure the best access and diagnosis for our patients? And that's, of course, what we worked with. So the European Cancer Organization, ECO is how we call it for short, brought together us from EHA together with a whole variety of other organizations, a real multidisciplinary approach. And very importantly, I'm sure you're going to agree with me on this, is bringing in the patient's voice. So the patient advocates were very much a part of this. We're very committed to believing that patients should have the major say, both in terms of how these things are set up and how they're used. And it was about sitting down and determining among us all what were the factors that we thought were important, what were needed for care in terms of patients being found, diagnosed, having a treatment plan, and then being offered treatment.
So you mentioned the multidisciplinary approach. You led a broad task force, including representatives from many organizations who are members of or involved in the European Cancer Organization. Can you tell us a bit more about who were part? You already mentioned the patients, but how was that task force, that broad group, composed?
Well, you're absolutely right. So a requirement of what we were looking at were organizations that were part of ECO's broader body. We considered the people who are perhaps most important in diagnosing hematologic malignancies, the hematopathologists. So what's a hematopathologist? Well, hematopathologist historically was the person that looked down the microscope at the biopsy and said, this is a lymphoma, this is a leukemia, this is the myeloma. Increasingly now, of course, they're also the person who brings together what we call an integrated report. That is not just looking at it, but doing the molecular testing, the immunophenotyping. What are the proteins that are expressed on the surface? So those people are the people who make the diagnosis on the basis of the bone marrow or the lymph node biopsy or whatever other biopsy we are providing to the pathologist. We had voice from in some countries, medical oncologists rather than hematologists are involved in the care. So making sure we were involving all the voices of people who may be looking after any patient with hematologic malignancies, radiation oncologists, people representing specialist diseases, and of course, members of representatives of patient advocacy groups who again were part of ECO's membership, to be bringing in that patient's voice. A real multidisciplinary approach. Radiologists, dietitians, physiotherapists, all the people who'd be involved not just in helping the diagnosis, but in helping the patients in their journey towards getting treated and getting better after their treatment.
So, John, can I ask, was it easy or was it difficult to find alignment amongst all these partners?
It was actually very easy to find alignment in what we were doing. It was very difficult in getting everyone together and keeping everyone engaged. So the process took longer than we hoped. I led this task force because, of course, it started while I was still president and while I was still chair of the European Affairs Committee. By the time, we got it published, that process took longer. But the process was never delayed by there being a disagreement among us what were those requirements and how things should be. One important component in thinking about this, in lots of the other malignancies, there's this whole question of whether you centralize care or whether we should have care much closer to the patient's home. Everyone appreciates that we want the care to be as near to the patient's home as possible. Hematologic malignancies are difficult. They're very complex. The WHO classification for hematologic malignancy now has literally, 300 subtypes of diseases. Getting that diagnosis correct starts the whole journey on how the patient's treatment is offered. And getting it wrong means that patients are going immediately down the wrong direction, getting offered the wrong treatment, and that just leads to all sorts of problems. We're also hugely aware that in hematologic malignancies, one of the major problems is there's a big delay between often when a patient first presents and when a diagnosis is made. This is patients with multiple myeloma often having 3 and 4 visits to doctors before being diagnosed. T-cell lymphoma, Hodgkin's disease patients often complaining of the same thing. So in other words, they're presenting to their doctors with clear symptoms. It's not being recognized, not picked up. The right tests aren't sent, and then people are sent away and a diagnosis missed. We also know, of course, that early diagnosis and prompt treatment can be very important. So that delay in diagnosis can be an issue. For this reason, our consensus was we should look to centralize that initial diagnostic care. I already mentioned to you earlier that the pathologists now are not just looking down the microscope, we're bringing together all these tests, these molecular testing, often the whole sequencing of the DNA of the tumor. Those tests are only available in large centers, and they're only available in centers who have the expertise to be able to do that type of analysis. So for these reasons, we all agreed that for hematologic malignancies, that original diagnosis and treatment plan should be done in a central hub. The plan then would be, if that treatment is complex and requires treatment in that central hub, then that's where the ideal treatment should be. But if the treatment plan is then established and that treatment plan can be executed nearer the patient's home, that's ideal. So everyone agreed on that. The next issue we had to agree on is whether we were going to want to write guidance that would be available everywhere now, or whether we should be aspirational to say, well, what you have right now is not adequate. What we want to write are what we call achievable but aspirational goals. That is, we want to set the bar high, largely so that those colleagues of ours, often from countries less resourced than we have in Western Europe, would be able to go to their organizations, their government, their sponsors and say, these are the requirements. This is what we need to be able to achieve there. And for us, that was hugely important to be able to support people in their aspirational goals to set up what is required in 2025 to be able to make a diagnosis of hematologic malignancy.
So these essential requirements for quality cancer care and hematologic malignancies are aspirational but achievable. Can you say a few words about how difficult, how challenging the very divergent situation is across Europe?
You're absolutely right. When we talked to, and we had, of course, representations within our task force of individuals working in less resourced countries who tell us, of course, they know exactly what is required, but don't have access to those issues. Well, of course, part of the European Cancer Plan should be that those people who are working in countries should have access to be able to, if they don't have it themselves, to be able to send the material into another centre where that diagnosis can be made. Often it's not necessary for the patient to go to the hub, but all the material should go in there to be able to make a diagnosis. The true aspiration, of course, is that those resources will be made available in each of the member states. But of course, the idea would be, well, at least we should provide centres that could provide that level of care until those other centres get there. It's a case of resources, and then it's a case of being able to understand, interpret, and then use those resources to make that accurate diagnosis.
Yes. John, you have explained very clearly why these essential requirements are so important. And it's impossible for us in this short period of time to cover all the recommendations really that the document contains. Am I right if I describe the essential requirements paper as a combination of organizational guidelines and recommendations?
I think that's absolutely true. Organization, in terms of what we considered is required to be part of that, what we call MDT or multidisciplinary team. Who are those people who should be at that meeting where a case is discussed, reviewed, everything brought together and a treatment plan comes up? In many countries, those requirements are already there. So we were not reinventing the whole wheel here. These are the ways in which it's done in for instance, in England where I am, that multidisciplinary team already exists in exactly this way. And so what we call hub and spoke model is already there. In other countries, this was a quite alien concept. And the idea that you even bring together a multidisciplinary team to discuss a patient's diagnosis was, well, why do we do that? Why is that even necessary? And often what it is people would bring in the expertise that they felt was required as the patient's journey progressed. We feel very strongly that everyone is there at the beginning. Everyone understands the needs. We can come up with a coherent plan that will offer, of course, we've said it already over and again, is important. That is equity. Everyone should have access to all of the resources that are necessary to get them through that very difficult and painful journey of being diagnosed with, told you have cancer, and then coming up with a treatment plan and getting through whatever that treatment plan might be.
That the fact that the essential requirements are so attuned to the needs of patients, are so patient-centered, I think that is one of its real strengths. I think it will play a very helpful role in EHA's engagement with policymakers and regulators. We're working hard as EHA to make sure that hematologic malignancies are not overlooked in implementation of EU cancer policies. There's the Europe's Beating Cancer Plan, for example, which has as one of its priorities the development of an infrastructure of comprehensive cancer centers. And you will agree with me that it's very important that hematology is an integral part of such comprehensive cancer centers, and that these essential requirements should be taken into account in organizing care for hematologic malignancies in that context.
I think it will come as no surprise to you, Robin, for me to say that I completely agree with what you're saying. There are two things I'm glad you picked up in terms of the guidelines. One is that it is very patient-focused, the importance of the patient's voice in terms of the diagnosis, in terms of assessing the outcome, in terms of, it's not just important to us that a patient's now in remission. A patient should be in remission and well and having the resources to rehabilitate themselves back into completely normal life. So I think very well, you and I worked together very hard within EHA to make sure that we had an increased patient voice. And of course, now we've got patient committee, and that voice was very important. But you're also right in terms of the second thing. That is, in often hematologic malignancies are not thought about in terms of cancer. The idea that a hematologist rather than an oncologist is the person looking after the patient means that in some countries, their voice is not heard within the whole kind of structure of thinking about cancer. So hematology's often got quite a quiet voice. Thanks to you, we've got a louder voice within Europe, but it's important that whole concept was not overlooked. And ECO, our European Cancer Organization, to their credit, of course, recognized this is important and, worked with us very closely. But of course, we hadn't been a member of that organization for all that long. So we ourselves, recognized the need to look for a stronger voice for cancer overall, but then consider it to be EHA's role to be the one screaming at the top of our lungs about remember the hematologic cancers and don't just focus on those solid tumors, which are, of course, more common. But the impact that a diagnosis of leukemia can have on, or myeloma can have on a patient is absolutely enormous, and that shouldn't be ignored.
We need to wrap up soon. So finally, could you explain who should be reading these essential requirements?
Well, I hope that that people looking after hematologic malignancies will look at these things. I'm hoping very much, and I know already this is happening, the patient support organizations are looking at this, but we also want the policymakers to be looking at this. These requirements are written very much with policymakers in mind. When we're setting essential requirements, this is the bar for the minimum at which we want to be provided. And if we're talking about those under-resourced countries, if they don't have that bar, they're not going to be able to just make, you can't just make these centers up yourself without the resources required to do this. So I'm hoping very much that the policymakers will read it. And if they're not reading it, I'm hoping you and your office will be making the policy available to the right people to be able to be aware that they're there. Presumably they're not going to read the whole guidance, but we'd like to make sure that they recognize where are the issues that we see are important. The important factor for us here is we know that there are huge disparity in terms of patient care, not just across Europe, but even within individual countries between people living in or near large cities and people living out, in the countryside. We need to think about how we're providing that care equitably across the whole country and, importantly, across the whole of Europe, because that's ultimately what the European Beating Cancer Plan is all about.
You have wonderfully explained why this is so essential, and we encourage everyone to read it. Thank you so much for having led this work, this very important work on behalf of EHA. We will work hard to make sure that it gets the attention, has the impact that it deserves. Thank you very much, Professor Gribben, John, for this and for taking the time for recording this podcast. And thank you very much to all the listeners for your attention. Thank you very much.
And I'd just like to thank everyone involved in the task force in getting this paper out.